How do you predict? Is there anything which you can predict this growth restriction? Hi, I'm Dr. Shruthi Reddy, working as a senior consultant in BirthRight by Rainbow Hospitals, Banjara Hills. Today, we are going to discuss about fetal growth restriction. Fetal growth restriction means, first you need to understand what is fetus. Fetus, when the baby is inside the mother's womb, it is called fetus. And if it is not growing as per the standards, we consider that as fetal growth restriction. Today, we have Senior Consultant Fetal Medicine Specialist, Dr. Gayathri, BirthRight by Rainbow Hospitals, to discuss about the fetal growth restriction. And we can clarify certain doubts. Generally, what we say from the patient's side, whatever the doubts they have regarding the growth restriction.
So, no, Shruti, yeah, I do agree that, the fetal growth restriction is almost like 10% of our population. And we do get a lot of referrals. You agree, as a high-risk, obstetrician. And for me also, we do get a lot of cases.
When we suspect the growth restriction, we send the patient for the scan. And routinely, when we do a growth scan in third trimester, which is in the 8th month, then sometimes we see that there is a growth restriction. So I just want you to enlighten our viewers regarding when do you consider actually the fetal growth restriction on the scan?
See, fetal growth restriction, according to the description, is below the 10th centile. That is, for example, if the baby is supposed to be 3 kgs or 3.2 kgs, if it is growing below 2 kgs, then probably, for a normal person, it is considered as a growth restriction. But we should also remember that not every, small baby is, unhealthy or growth restricted. Therefore, we need to use certain parameters to diagnose the fetal growth restriction.
Yes, as we know, not all small babies are unhealthy.
Yeah.
So only when you consider that the growth is really unhealthy, then you label the the baby as a growth restricted.
Exactly. It's similar to, not all people who are 5'4" or 5'5" are essentially unhealthy, like somebody who is 6 feet height, isn't it? So similarly, babies, some babies may be 2.5 small and they are called constitutionally small but otherwise healthy. But these growth restricted fetuses really, have some issues. So how do we diagnose this? Suppose you send a patient to us, we check the growth of the baby. And if it is below the, 10th centile, then we suspect growth restriction.
So basically, you have the growth curves.
So it's the trend of the growth which is more important. If it's not, reaching up to the, expected stage, and there is a suboptimal growth as compared to the previous scan, then probably we can consider it as a growth restriction. Added to that, we need to add on the other parameters like looking at the Leica and something called the fetal Dopplers. So these will, add on to the diagnosis of the fetal growth restriction and also the clinical examination of the baby. So we look at your reports, and most important thing is also we need to check the, something called the clinical dating. So we'll get this dating by looking at the early scans.
For our viewers to understand, what do you mean by dating?
So dating is to know exactly the gestational age of the fetus at that point of time. And by that, to estimate the, clinical, estimated due date, that is the date of delivery.
Yeah. So for us to understand the growth problem, basically the viewers have to understand what is the gestational age. Gestational age is nothing but the age of the baby which is inside the mother's womb. And we start calculating that from the first day of the last menstrual period. And sometimes it varies even with that. So we consider the gestational age based on the scan which is done at 12 weeks, which is done for the NT scan. So based on that, we give the estimated date for delivery exactly at the end of 40 weeks of pregnancy. So the previous scan reports where they have taken the measurements of the baby and where they actually dated the pregnancy, these scan reports are important for you to plot the graph and then say that, oh, this is what is the growth restriction and how bad it is.
Yeah, generally we take the, the NT scan, the length of the baby. We call it as the CRL, crown rump length. And that is the exact, thing, because for any, stature of the babies, that length is constant.
Based on whatever, irrespective of the parent stage, the baby size at that age, remains same, which is at 12 weeks, and we date the pregnancy.
Suppose sometimes we don't get that because say some people get the scans at 20 weeks or so.
Some people miss the scan in the first trimester.
In such cases, we take the, like the other parameters like the head circumference or the aggregate of all of them to date the pregnancy. And everybody should remember that once the estimated delivery date is, already estimated, it should not be changed.
It is only the growth which might change, and that has to be explained to the patient.
So that we will do it as centiles.
Growth centile. Percentile. Yeah.
Percentile.
So basically when we have this growth scan report, what else you see on the scan? Apart from the weight of the baby, what else you see to know whether the baby is safe inside or not?
See, we also need to look at the fluid surrounding the baby. That is called amniotic fluid or the amniotic fluid index. And also look at the baby as a whole, like estimate the structure of the baby, look at the structure of the baby, and also movements of the baby, and something called the blood flows within the which are going to the baby,
So blood supply to the baby.
Blood supply to the baby. And that is something called the Doppler flow studies, which is a very important study while we are diagnosing the fetal growth restriction.
Okay. So basically when patient comes to us with that scan report, which is like a growth restriction is explained by your fetal medicine department, and when they come to us, so they'll start asking that, is there any treatment for a fetal growth restriction?
Correct.
So is there anything which they can improve the baby's weight based on some, is there any medication for that? So what is your say on it?
See, essentially there is no single, medicine or a single drug to treat the fetal growth restriction. Because if we look at the reasons for the growth restriction, it is essentially the placenta. Isn't it? The placenta. Placenta is the specialized organ which grows along with the baby, which supplies the oxygen and nutrients from the mother to the baby. And the placenta develops by the improved blood flow to the uterus. And the blood flow to the uterus increases by almost 10 to 15 times during the pregnancy. And if there is a suboptimal increase in this, blood supply, then probably this may lead to the growth restriction in the future. Therefore, how, early it happens, this growth, whatever that blood supply, or how severe it happens leads to the types of growth restriction.
So when do you see, what is the earliest gestational age where you see there is a growth problem?
See, in fact, if you ask me when does it start? It starts very early itself. But when does we diagnose? Essentially, you guys will, look at in the clinical checkups and detect the growth restriction generally after 20 weeks of pregnancy by your, symphysiofundal heights. But this growth restriction, it happens very early in the pregnancy when the placentation starts. So generally the blood vessels which are going to the uterus, they transform into that is called the placental remodeling. So these vessels, the spiral arteries we call them, that transforms to these placental vessels. So therefore, which increases by the 10 times or 12 times in pregnancy, essentially increasing the oxygen and also the nutrients to the baby.
So basically, growth restriction is mainly related to the placental issues.
Yeah.
So if the placenta is nothing but the root system for the plant, how the root system is to the plant. For the baby growth also, placenta is like a root system. If the root system is not formed well, then we can expect growth restriction. But do you think there are any other reason for growth restriction?
Yes, of course. See, we are talking about the root cause, but there are the reasons for why this, blood vessels get, reduced is maybe because of the mother's factors like sugars or BP, particularly BP in pregnancy, or the baby's genes itself.
Yeah.
If there are any genetic problems or the baby's genes are defective also may lead to the growth restriction. Third is this viruses, something called the congenital infections, particularly the cytomegalovirus or the toxoplasma. See that generally these flu or cold viruses which happen in the early, gestation, they don't, infect the placenta or affect the placenta. But these congenital infections might, infect the placenta leading to the growth restriction.
So basically torch infections, which can most of the common reason for early growth restriction. So whenever we diagnose growth restriction, the first question the patient asks is, What could be the reason, doctor? So how do you have any test to know that is there any reason for this growth restriction?
Generally, most of the times there might not be any reason for the growth restriction because again, the placenta may be the culprit. But again, we need to, in the cases of the early growth restriction, which happens in almost 20 to 30% of all the growth restrictions, we need to test the baby because we need to know what is the reason for that. And that could be because of, the amniocentesis, that is the fluid tap test where we draw the fluid and test then for the baby's genes which are there. Or sometimes in the case of suspicion, even the viral infections of the baby like the torch infections, also we can test from the amniotic fluid. So once, we rule out all the problems from the baby in terms of the structure of the baby and the genes of the baby and the viral infections, then it is said to be, the placenta would be the reason for the, like the early growth restriction.
So basically when there is a growth restriction, we are supposed to check for any infection screening, for any genetic disorders, for any placental problems, or if the mother is the reason for the growth problems, like in example, like high blood pressure or uncontrolled sugars or certain kind of autoimmune disorders, we need to look for those things. And then if we can correct it, we can correct that. So, but once the diagnosis of growth restriction is there, generally, the first question what my patients ask is there any treatment to this? The first is the diagnosis and the second is the treatment part. So once you diagnose that there is a growth restriction, and if you say that there is the placental issue, which is the reason for growth restriction, they will first ask, what is the treatment? Is there any medicine for that?
Essentially, there is no cure for the growth restriction. And but we should also remember that, nature is so great that there are many adaptive mechanisms which happen inside the baby. Once the baby's genes are normal, no congenital infections, there are many adaptive mechanisms which happen to the baby inside. So when there is a fetal, growth, which is there will be a redistribution of the blood to the baby's, brain, the adrenal, the kidney, the essential organs. And therefore, they will not be, there may be a change in the size of the baby, but essentially the other health factors might be normal. So we keep monitoring this, the health of the baby inside, so that, the second most important thing, which is very important, is the gestational age at which the delivery happens. Suppose because it is growth restricted, we can't deliver off the baby because it's through that.
That is what. First question is, they say that what is the treatment, and then immediately they come and ask me, when do you deliver this baby? So as I always tell the patient that, okay, if the patient is protein deficient, we try to correct that. That suddenly, if there is a problem like nutritional deficiencies, we try to correct that. Hydration is important. And they ask me that, okay, doctor, if I take bed rest, will it help? Will it help the growth of the baby? But actually, bed rest doesn't help. That is what I keep telling them, that it is not the rest. It is good diet, good hydration, without much of stress, and good sleep. These will play a role. And if somebody is like nowadays, we are having so many working women, working mothers. So we tell that if it is too stressful in the workplace, it is better to apply leave and then take good nutrition, sleep, and then diet. That will help. And if there is any blood pressure related issues, we tell them that, okay, correct this, it will help to a certain extent, and the blood sugar control. And after this, they ask the next question is, when do you time the delivery?
Yeah.
So once we diagnose, I just tell them that, okay, it is between the fetal medicine department and it is between our department. We discuss the timing of the delivery. So when we have this growth restriction, we tell the patient that, okay, come after. We keep monitoring. Rather than the medical treatment, I always stress on the fact that it needs monitoring. So that as the baby is as long as the baby is inside the womb, it is the risk versus benefit ratio we take, and then prolong the pregnancy. As much as possible, we try to prolong the pregnancy. But when it reaches to a point where the baby is not safe inside, we tell the patient to deliver the baby. So as a fetal medicine specialist, you tell the viewers that when do you decide the timing of the delivery? Do you get to decide when to deliver the baby based on the scan?
The most important factors which determine the mode on or the timing of delivery are how well the baby is inside. So is it keeping its health inside? And the second thing is the gestational age at which the delivery should happen. Because, see, prematurity has its own complication.
Yeah.
Therefore, we need to prolong the pregnancy as long as the baby is healthy inside. How do we know that the baby is healthy inside? So that's the reason the scan comes into play at that point of time, apart from looking at the weight of the baby.
But they suddenly start asking that the amniotic fluid is less. The scan doctor says that the fluid is very less. So does it harm the baby right now? And then it's better to deliver the baby. That is what they come to us with that question. So what do you say?
The amniotic fluid is the index of the placental transfer. So as long as amniotic fluid, the weight of the baby and these blood flow measurements are normal inside, we tend to, in spite of a smaller baby, still it is healthier inside.
But they have the problem that if the fluid level is less, they start getting worried about
it's like, see, nowadays it's not the fluid which matters to deliver the baby. It's just to monitor the baby. The factors which influence the delivery are, the very abnormal Doppler parameters or your CTG measurements
or the blood supply. So basically the blood supply and the heart rate recording.
Heart rate recordings, which we may do, a graph which is there. And, and the other thing will be which are worsening the mother's BP parameters.
Yeah, so we have to consider the maternal condition and the fetal condition when we time the delivery.
Exactly.
And as long as the mother's condition is good, we try to prolong the pregnancy as long as the baby's condition inside the womb is good. So basically, we depend on the Dopplers. So when we say that early delivery, how early can we deliver? In your experience, how early the babies who had delivered with growth restriction had survived at BirthRight by Rainbow?
Essentially, it is the blood flows to the baby which are important. And if that is severely affected, that is more than 75 to 80% of the flows are restricted, that leads to, something called, hypoxemia. That is, oxygen levels in the baby will be reduced, which leads to the acids which accumulate to the baby and leads to the problems within the baby. So at that point, we need to deliver off the baby. And at BirthRight by Rainbow hospitals, there are cases that the smallest baby which was recorded is 375 grams. And this monitoring we started doing from the 6th month itself. And do you think, the setup or the, the way the baby is delivered?
That is what I see. It is not just the timing of the delivery. It is the place where you deliver is also important, because it is not the pediatrician attending the delivery at the time of delivery. It is the teamwork which is involved after the baby is born and the baby is gone into the NICU, 24 hours round the clock, whatever the monitoring has to be done by the senior consultants. All those facilities will definitely make a difference in the outcome. Because these small babies, when we are trying to save them, it's not just the saving the baby, it is to be a neurologically intact baby.
Good.
Infection rate has to be less. All those things matter a lot. So that is the reason I keep encouraging them that better you deliver at a setup where you have all the facilities and the baby will be taken care after that. Basically, in managing a growth restricted baby, it is more than from the obstetric side, it is the pediatric side, which matters a lot when you come to these results and the outcomes of the baby. So that is the reason I keep stressing on the fact that it has to be done in a tertiary health center.
So see, these Dopplers are more, or the blood flow measurements, they are more effective until probably 36 or 37 weeks. Beyond it, what are the other parameters you look at while monitoring the baby?
We always look for the biophysical profile, what we say, where we check for the baby movement.
Yeah.
And the other thing is the NST, what we say. It is called the heartbeat trace recorded on the paper. So if both are fine, we try to prolong the pregnancy as much as possible to 37 weeks and deliver. At the same time, the mode of delivery also is important.
Yeah.
When the cervical birth canal score is good and it is favorable for normal delivery, we try to do normal delivery. Though, as you know,
Where will you consider cesarean section in this?
yeah, if your report says that there is a problem in the blood supply, especially absent end-diastolic flow or reversal end-diastolic flow, where you report those two conditions, then the chances for normal delivery definitely comes down a lot, because labor is also a stress to the baby. So when the baby is already compromised state inside the womb, you cannot create more stress to the baby during the labor process. So that is the reason in these cases we tend to go with an elective cesarean section. At the same time, we inform the pediatricians, neonatologists to be there. And what we see in the late onset growth restriction is maintaining the blood sugars. The baby, once the baby comes out, the first thing is they look at the oxygenation of the baby, if the baby is crying immediately or not. And the second problem, what we see is the sugars. So though the baby is not admitted to NICU sometimes, we stress on the fact that the sugars of the baby has to be checked.
So you meant to see the metabolic effects or, to be monitored for few days after the delivery.
Yes. For the first 48 hours, we try to look at the sugars in the baby, even if the baby is in the mother's side, and if mother is able to feed the baby or not. And if it is not sufficient, we may have to explain the situation to the patient and then ask the mother to give the formula feed based on the neonatologist's advice. So those things will be taken care.
So the maturity is, more in the cases of the smaller baby.
Yes.
By 37, 38 weeks only, they reach the maturity early. And the other thing they do ask is, what would be the neonatal effects after the delivery? Would they do well? Because, see, generally we estimate the baby 700, 800 grams. And they say that they'll do well with a proper monitoring and delivery. And what would be the, after effects of this growth?
That is what, whenever patient comes with these doubts, we generally advise them to have a neonatology counseling.
Yes.
Where the neonatologist will speak to the parents and tell them what to expect when the baby comes out at that particular age as well as at that particular weight. So I explain to the patient that if everything else is normal, it is only the growth of the baby which is not that optimum, then by the end of 3rd month, that baby will be on par with the healthy baby which is born as 3 kgs.
So you mean to say that, this multidisciplinary approach is very important, being the obstetrician, fetal medicine person, and even including the neonatologist.
Yes.
Because many people have that and they do terminate the pregnancies just because they are smaller. But really they do well. And with the help of the neonatology team, they do, a counseling before the pregnancy and take over the pregnancy in the next, after the birth of the baby.
Yeah. Definitely, I recommend it is a multidisciplinary. It is not one doctor who has improved the outcomes. It is the obstetrician, it is the fetal medicine specialist, and it is the neonatologist who is taking care of the baby.